The topic of this panel discussion is advancing the DDOT program in North Maharashtra.
Good morning, everyone. Today's panel discussion is about our local issue that in our region the deceased donations are very less, and we are struggling. But now, since last couple of years, the movement about the organ donation is happening, and we want to take this program ahead. So that's why this is the session on the how we can advance the program of deceased donation in North Maharashtra. The government representative from the Deputy Director of Health Services is invited. So anyone from the DDHS here in the audience? Dr. Yogesh Chitte or the Additional Director? I request Dr. N. Gopal Krishnan from Tamil Nadu to come on the dais for this session and to guide us about the how we can start here the program. When we decided to go for this midterm ISOT, the main aim was to increase the number of deceased donation, and the theme, if we see the of the meeting, is controversies to consensus in deceased organ donation. So pertaining to this, I will ask the first question to our NOTO director, Dr. Anil Kumar sir. What are the steps taken by the government to increase the social awareness, or what is or social movement for this organ donation?
Namaskar. Actually, yesterday I showed in my presentation that like in last 1 year this awareness has been boosted a lot. You know, we organized Angdan Mahotsav in the month of July, then organ donation day in the month of August. Then we had this organ donation Mahotsav continued, and it was part of the this 75th celebration of the country's independence. And then during the Modi ji's birthday, 17th of September, we launched a digital registry which is Aadhaar authenticated. So now the citizens of the country, they can register their pledge to donate organ after their death, and that pledge data is easily accessible through their Aadhaar ID. Then we focused on reaching the masses to the rural areas also. So it was part of every campaign which the government was running, like Ayushman Bhav initiative, Viksit Bharat Yatra. So, and those yatras, those vehicles which were going right up to the doorstep of the people, so they were carrying this message of organ donation. And even the pledge drive was continued in the rural areas also. And so this was boosted a lot. And we run a social media campaign very aggressively. We organized a mega pledge registration drive also in Agra. This was a very big event, and where 10,000 people gathered at under one pandal, and they pledged for organ donation. So we have been doing a lot, and we'll try to increase more in the audiovisual sector, but social media, which is now is more, we are on Facebook, Twitter, Instagram, YouTube, so we are there everywhere. So we are trying to reach to the masses, but we find the awareness is more needed in the medical profession, because there is always a doubt in their mind, like 2 days back I received a query that this case is not a medical legal case, but do we still need to inform to the police that we are going to go ahead with the deceased organ donation? So if such kind of doubts are there, the case is not a medical legal case, then you are not required to approach a post-mortem doctor or inform the police. It is not something that you are going to do is illegal. It is permitted under the law. Only in case of a medical legal case you are required to inform the police. But this query came from a very big tertiary care institution where the donation was going to happen. So the doctor community has to educate themselves.
Yes. Thank you, sir. And as he rightly pointed out that there is some physician inertia or difficulties to initiate the program from the ICU. So moving on to our next question for Dr. Atul Mole sir. So as Dr. Anil Kumar sir said, there is some hesitancy in the healthcare professional. So there is a concept of some transplant procurement manager in the Europe. So how do you train our ICU staff or intensivist in terms of the brainstem declaration or initiation of this organ donation? So what do you feel about the relevance of this transplant procurement management in perspective to the Maharashtra or India?
So I entirely agree with Dr. Anil Kumar sir that it is the medical community which really needs a lot of education and awareness, because they are the ones who are going to start the program. And the program starts, the disease donation is going to start from ICU. So you are right that intensivists are one of the key stakeholders. So from ZTCC point of view, we have been regularly involving intensivists through the Critical Care Society as well as different other forums, and having regular training sessions and awareness sessions for different ICU doctors, especially those who are recognized transplant centers or NTORCs, to sort out their problems. And then we also look at their the difficulties that they have. We have our managing committee meetings with them and listen to them, their grievances, their problems on the ground, and try to address them. The second part of the question was about retrieval. Retrieval is a key issue because often it happens at odd hours, weekends, holidays. So there is, first part is the capacity building. We need to have enough capacity of surgeons who will be available to us at every given time or place, 24/7. We have a large area to cater from tier 2 to tier 3 cities and transportation of organs. So we have to make sure that the retrieval is done properly by a trained surgeon. We have regular meeting with the surgeons as well and try to establish communication between different teams so that the different teams will help each other. We have not yet come to a point where we have an independent retrieval teams which are independent of the recipient centers. At the moment, the retrieval responsibility lies with the recipient centers. They can obviously collaborate and take help of other centers, and they are free to do that. And we are actually facilitators for that process. So we will like to move to a system where we will have independent retrieval teams who will be trusted and who will have enough skills, training and experience, because what we have seen is that in around 5% of the donors is complex vascular anatomy or different anatomical anomalies which need to be tackled to ensure that the retrieved organs has a good quality so that the graft functions well.
Thank you, sir.
So next question is with Mayuri ma'am. So can we encourage or make it compulsory for NTORC registration in all hospitals with ICUs and OTs? What is your take, ma'am?
Sir, as rightly Dr. Anil Kumar sir and Mule sir told that there is a need of education to the NTORCs and local hospitals regarding the brain stem death identification and referrals is much more important, because currently we are focusing only on the transplant centers. So we are losing that donor pool from the NTORCs and local hospitals, which is really needed to be emphasized. And I feel that yes, NTORCs to be sensitized, and they should be actually I can't say that it should be compulsory, but we can emphasize them positively so that they can come forward and contribute in the drive of organ donation.
Thank you. Sir.
Regarding the NTORC issue, can we have a situation, I just wanted to ask you, when we recognize a particular hospital for the whatever work they are doing from the state health department, at that time can we sort of give them a suggestion regarding recognition for the NTORC also at the same time? Because I think a lot of hospitals, they are not aware about this, and when it comes to the organ retrieval, then there is a cadaver available but the hospital is not recognized. So that becomes a very peculiar situation. So when you renew the registration of the hospital, at that time can it be done?
Basically, any hospital which is doing a major organ transplant is automatically qualified to do retrieval, multi-organ retrieval. So even if it is a kidney transplant center, they can do multi-organ retrieval. So that is one part of it. Second is, yes, we would like state government to take step in and just find out which facilities or which medical colleges they have, because I think any medical college which is teaching MBBS must be having a ICU facilities as well as the operation theatre facilities, and you are required to constitute a brainstem death committee, because which has to be approved by the licensing authority. So when you are applying for approval of your brainstem death committee, just propose, because you have to seek approval in two categories. The one is of the neuro experts, or if not available, then anesthetists or intensivists. So give the list of all your neuro experts and all your intensivists and anesthetists, like who are not part of the transplant team, and get them included in that category. Then second is the independent specialist, like who could be a specialist like ENT specialist, eye specialist. So give all those lists. Get maximum people including in the certification of this brainstem death committee. So because like whosoever is available can do the certification, but I would advise that they should be trained, because it's not that they are sometimes they are not exposed to certifying the brainstem death. Even if they are neuro experts, or still they are not used to certifying the brainstem death. And in the brainstem death also, you have to ensure that they finish the entire clinical examination, because ancillary tests are not mentioned in the act and the rules. But complete physical examination, whatever is listed in the rule, that has to be followed. So NTORC state can themselves identify the centers and recognize them as NTORC. There is no registration fee. They only need ICU, OT, brain death committee, and a transplant coordinator. Transplant coordinator from the staff can be identified. Even a nurse could be identified as a transplant coordinator.
Yeah, thank you, sir, for your comment on that. I will ask next question to the N. Gopal Krishnan, sir. There is a significant amount of donations happening in the Tamil Nadu, and it is a role model for all of us from India. So how we can implement that Tamil Nadu model in the other states, or especially in our region? So how we can increase that donations?
Thank you very much for inviting to share my views. Currently, I am holding the additional responsibility as Member Secretary, Transplant Authority of Tamil Nadu for the past 7 months. In my analysis, actually, addressing individual component of the program will not take us anywhere. We need to understand the program in its entirety. So, I would just share my reflections. There are 5 components in the entire program. One is the political dispensation. the will of the political class. Then the bureaucracy, how determined the bureaucracy is. The third one is the technocracy that we are, the doctors. The fourth one is the visual and print media. And the fifth one is the common man. Currently, what is the prevalent situation in India? You can't expect a better push and encouragement from the political class now, because our Honorable Prime Minister himself has talked about Angadan at least 3 times in Man Ki Baat, and he keeps talking about it. And our respected Chief Minister of Tamil Nadu, he himself has come forward to pledge his organs, right? So almost the same thing is happening, and almost this is. Second thing is that bureaucracy. The health secretary of every state is too keen into that, and it is one of the common issues of review, monthly review at the national level. So they are all very keen to push. Third thing is that thanks to our media, 99% of the coverage of organ donation media is positive. Very rarely we come across negative coverage. The fourth component is the common man. There is increasing a level of acceptance in the common man. There is no data as to is there any difference in the acceptance of the common man in different states. Actually, we think common man is not accepting, but it is not so. From our own experience, I can say more than 75% they come forward to donate even to one counseling. Where is the problem? The problem is with the medical fraternity. And again, there are 5 components in the role of the medical fraternity here. Number 1, identification of the brain death, brainstem dysfunction, identification of the brainstem dysfunction. Second thing, certification of the brain death. Third thing, most crucial, maintenance of the brain dead donor. Fourth component is the retrieval process. The fifth component is the expertise to do surgery. So all these are the 5 components, and in the medical fraternity component, all the 5 components have to be dealt with. So unless we address all these things, the program will not take. Just addressing one component of it will not. And we should create an ambience and atmosphere and a mechanism for a seamless flow of multi-dimensional flow of information among all the components of the program. We all have to understand it is a very grand teamwork. Just one component of the team will not take it anywhere.
Yeah, thank you, sir, for your remarks. And due to, as we are running short of time, so I will ask Anil Kumar, sir, to give final closing remarks on this panel discussion.
Yeah, basically, you have to identify the institutions where you can set up the program. It is important to identify where the experts are available. I think in the North Maharashtra, Nasik is the main city where this transplant program can be developed. I was checking the cities, Dhule and all those. I think they are smaller setup. Nasik is the biggest. So you can act as a mentor, like your institutes which are located here. They can act as mentor institutes and develop a program in the government institution also. Because unless you have programs in the public institutions, it will not, it will earn more public trust. It will be more, you will be able to produce more trained doctors. So, because in the government institutions, the training will also be under focus rather than only provision of the services. So, all the best to you and for your endeavors, and I wish you all that you will develop very good programs here in the North Maharashtra.
Just one comment. Sir, I appreciate all the inputs from the panelists, which are really enriching. One thing that I have seen during my work, not that we know that our transplant programs are mostly running in the private sectors. The private sectors do have not only the decision making, not only the critical care respondents, not only the nephrologists and the surgeons, but the CEO on top of it, from whom a yes nod is very, very necessary if the critical care people or intensivists, they are inclined to declare their death. So these in Kolkata, where most of the donations are, most of the transplant is going on in the private sector, the donations are minimum from the private sector. I feel not that there are the untrained or uninclined critical care people are over there, but it's a nod from the yes, nod from the CEO level as well. And we should think how we can implicate our bureaucracy in the government system to the private system CEOs interacting to set the ball running in private sector as well. Thank you.
So, thank you, Arpita madam. And she has rightly pointed out that within the hospital, the push has to come from the top, and therefore the administrators and CEOs and medical directors are also one of the major stakeholders, and we have meetings with them as well regularly.
Thank you so much. With this, so we conclude this panel discussion.